Invitation. Just to start with, I think what's been discussed already and what's going to be discussed later is potentially more important than what's available pharmacologically, but we need to work together as a group and do clinical trials and find something that might work as a treatment. Even though so far things have been negative, you don't know if you don't try. And this is just, I'll just quickly run through this. I don't want to go through a lecture on motor neurone disease, but it isn't, it is rare, but it's not that rare, and we're recognising it more and more. And a neurologist's role in the past was sort of to diagnose the patient, and then that was it. I think we're learning more and more that there's a lot more that patients want from you than just being given a diagnosis. As I've grown in my career, I've learned more and more with each patient what the challenges are and how important it is to very early link them into services. One thing that we're expected to do is try to label a type. There's some benefit to that in that there are some variants that have a different longevity. For example, if you have this very rare syndrome, which I've only seen a couple of times, called flail arm syndrome, you tend to live longer. So there is some benefit to that. But the benefit of knowing what type it is just to help plan people what to do. For example, if someone comes with primarily swallowing or speech disturbance, it's very important to just quickly get on to deciding important things about language and swallowing, as well as everything else that comes with general care. It is very difficult to diagnose, and there's no single test, and it can take many months to diagnose. And one of the things that is important is to get that diagnosis early and not let the patient live with uncertainty. It helps also with regards to support, because if I don't give someone a diagnosis and they're 45, they're not going to get NDIS until I give them a diagnosis. And that's something that we're learning as we go, how to link the funding with the patient. And there's some criteria that is more relevant from a neurological perspective. You don't want to get the diagnosis wrong. I had one person referred to me who had this condition, and that's treatable with immunoglobulin therapy, and we did the right tests, and he's still alive 30 years later, getting intravenous immunoglobulin. So rarely you might find a different diagnosis, but more often than not, I've had people misdiagnosed as having some neck problem because their arm's weak, and they had surgery and surprisingly it didn't work. And by the time they got to see a neurologist, it was a year from onset of symptoms, and you're just delaying proper care. So it is important to get the diagnosis correct. And I'll just move from this. So what is the cause of motor neurone disease? We still don't know. We think that it's a combination of environment with unknown elements in the environment. Genetics, we're recognising that more and more, that there are genes that cause this, and that's why genetic counselling is relevant. For example, if a person just had a new onset diagnosis and there's no family history, there's still a possibly up to 7% chance they're going to have one of these genes. So genetics isn't that irrelevant. And also we might see some other things that happen, like, we don't understand this, but premature ageing of motor neurons as part of the circle. But this has led to sort of some ideas about treatments. So intervention, as has been mentioned, is multidisciplinary. Drugs are just one arm of this. And the first drug that ever came out was called riluzole. And it became clear that one of the likely reasons that people deteriorate with motor neurone disease is that there's some excess damage happening to your nerves. And there's lots of theories behind that. We release these things called free oxygen radicals that happen from just normal living. They things that maybe the liver doesn't clear, they get into your system and then they can cause damage. We also have situations where there are some chemicals in the brain that excite the brain, and if you have too much excitation with this chemical called glutamate, that might stress out the nerve and lead to damage. And that was the theory behind riluzole, that there was too much glutamate and this blocked glutamate. And busy slide, but in these trials it showed a benefit. Unfortunately, that benefit is prolonged survival on average by 2 to 3 months. It's not marvellous, but if you ask someone, would you like an extra 2 or 3 months, most people will say yes. And there is some caveats to this, because when they've pooled things, there are some trials that excluded people, and if you look at a lot of range of trials, the benefit can sometimes maybe even be longer than that. It could be over 12 months. Just because that's the average doesn't mean someone might not get a longer benefit. And so we routinely would recommend trialling this on a person who's been diagnosed. There are some exclusion criteria based on PBS. If you're no longer ambulant, for example, if you have severe respiratory failure, you can't receive it. And you'll see some people on it, some people not on it, and then some people won't tolerate it. I'm fairly liberal about what's respiratory failure and what's walking. I'm not going to deny someone because I'm being pedantic and picky about definitions. There are some side effects with this drug. The most common are nausea and fatigue, and some people could get liver function derangements. And so I have had patients where we decided it wasn't helping them in the way that they wanted. They were getting too many side effects, and so we withdrew it. There are a lot of trials starting to happen in motor neurone disease. The sad thing is there's been over 40 negative trials. And most of the trials are based on success with animals, particularly rats, going on to humans, but when they've gone to the next level, they haven't worked. The same thing applies to other diseases like stroke. And we need to sort of maybe think about how to design trials better. Which are the best patients to select? What outcome measures are we really wanting to identify? And that's something that's a learning process for for motor neurone disease and motor neurone disease research. One thing that's become a standard, and whether this could be improved, is a functional rating scale. So this is the ALS functional rating scale. It's what a lot of these trials use to decide whether someone's responded. And it's got 9 categories, and they score from 4 to 0. So if you're completely normal, you score 40. If you're extremely disabled, you score 0. And I think that they're all very relevant functional things that you should look at, but you have to take this into context if you see a study that says there was a 1-point improvement. So one drug that's come out recently, but it's not out in Australia, is called Derivate. And as I said before, this drug works as a free radical scavenger. So the idea is that it will pick up toxins that are oxygen-based, that are released because of something that our body can't metabolize and is leading to nerve damage. That's the theory. And in this particular study, the rating scale improved by 2 points. But it was highly significant. And this has led to it being available overseas. In America, it's approved for use, for example. In Australia, we haven't got it yet. But this is just some complex plots that show that it favours a benefit in terms of when compared to placebo, for score outcomes, and also for lung capacity. So what's the problem with the Derivate? Well, it's very costly if you wanted to receive it. I think, I know one patient that's going to Japan to get it, for example. But it's a 60 milligram dose over 1 hour, but the problem is it's once a day intravenously for 2 weeks, then you have a 2-week break, and then you do this cycle for at least 6 months. And you don't know, the trial stopped at 6 months. You don't know, does this need to be given for 12 months or forever? But that course of treatment is going to cost $80,000 US. Now, will our government approve this? I don't know. It's a very expensive treatment, but there is some push from the research people, particularly BMRI at Camperdown, to see if we can get this available for our patients. An interesting trial that recently came out was, because this looks very simple, it's well tolerated, was high-dose vitamin B12 given intramuscularly twice a week. In this study showed that if you picked a patient early into the disease, so someone who had motor disease for less than 12 months, they had a reduction in the deterioration of their functional scores. And because this is very safe, I don't know, like if you get an early patient, you just tell them, I want to give you high-dose vitamin B12 twice a week. From now on, what's the harm? But whether we should be doing more research in something like this, I don't know. But it's just something that came out very interestingly recently as probably a very safe treatment option that you could consider for your patients. This is, the thing is that they still decline, but just they decline less than placebo. So this is the 50 milligrams, and that's the placebo, going over almost, or going over a 180-week period. So what are some trials that, this is on the MND New South Wales website, what are some trials that are going to happen very shortly? Another exciting potential treatment is copper, because copper is also a scavenger collector. And the idea of copper came from the first ever gene called SOD1, superoxide dismutase, relates to copper, and that was the first gene identified in motor neuron disease. And there's a lot of Australian flavour to this because Concord was an integral part of recognising that first gene with Professor Nicholson, and now Australia is the leading site. This drug was developed in Australia, and Macquarie has done a phase 1 study with Professor Rowe, and they're going to do a phase 2 study. The phase 1 study was really to identify how safe it was to give this and what may be the best dose. And we can't take too much yet from this because there was only 32 people that were in this study. They were broken into 5 different dosages, so there was a maximum of 7 people per dose. But it found that 72 milligrams was probably the best dose, and those people stabilised, but 7 people is not a lot to use to tell you that this is an answer. They compared those 7 people to a large cohort of over 8,000 people that had motor neuron disease in a database, and the average rate of decline is 0.3 points per month on that rating scale. They decline much less than that, and that's all in favour of going forward with such a trial. And I'm sure my patients and patients coming to Liverpool MND Clinic will be, jumping in the queue and waiting to get onto such a trial when it goes to the next phase. It's going to start very soon. There's also some other phases looking at other studies that have been looking at other treatments and whether they work. This is a drug that's supposed to help stabilise muscle. It works by slowing calcium release from muscle, and this sort of somehow supposed to improve muscle contraction. But the early phase study for this trial was negative. It didn't seem to make a difference. There was some suggestion that there was some improvement in some parameters, and they want to do further studies on this. But again, so far, a small study that was negative. This is a study that was done in Sydney and Melbourne. It's using a drug for HIV. The theory behind this is that in motor neuron disease inside the cells, you get a sort of this change in enzyme activity, and you get a similar effect to what would happen if you had HIV. And if you gave a drug that might reverse that, maybe it'll work. This trial has finished its phase 2 results, and there is an upcoming phase 3 study. I don't know the results of that trial. There's also another trial of a drug called Tecfidera, which is an MS drug. I'm very familiar with using this drug, and it's quite safe and well tolerated. It's also thought to possibly work by reducing mitochondrial and oxygen stress on cells. We don't actually know exactly how it works in MS, but cell models suggest it could do those things. So they decided to try it in motor neuron disease, and we'll see. The recruitment has completed. I don't know the results of this one either. And then there's some other studies on cannabis. I'm learning as I go, because I was asked to give this talk and I had no idea that cannabis might actually slow the disease. I thought it might just help pain and other symptoms. But there's now currently a trial done at Gold Coast University Hospital looking at cannabis oil as a treatment that might slow the disease down. And there's also other drugs that might improve lung capacity that are being done. The pleasing thing here is that these are studies being done in Australia, and I'm like when I looked this up and I saw this, wow, we're world leaders here, and I'm very impressed by how many studies are being undertaken. I've excluded on the website, there are allied health studies on improving quality of life. They're very important, but I decided I'll just focus on clinical trials here. And that leads to what a neurologist can do in terms of medications, or a physician. This is a really big challenge. I find it extremely difficult to help with what repertoire of drugs we have available. This is a list of things that people want to know, and in terms of drugs, things that we are often asked is what's going to help reduce my cramps, and the answer is it's very challenging. But these are some things that have been listed as possibly working. So you could, I use non-evidence-based treatments here. Quinine is an option, so then you could offer them tonic water. Magnesium is not listed here. I've never tried pickle juice, but it's listed as an option. What's there to lose? Marijuana, well, there's ways of getting that outside of paying $700 a month for a spray. And then there's baclofen and gabapentin, and also pregabalin or Lyrica. We try these things, and it's a bit hit and miss. If the patient subjectively reports an improvement, I'm happy, and so are they. There's also what can you do to reduce spasticity. That is also challenging. Some things that I tend to go with there would be something like baclofen. I'm very careful with baclofen because spasticity can sometimes also be helpful for maintaining muscle tone and being able to stand. And if you take that away, the patient then reports weakness and they can't walk as well. And so you have to decide what's more important. And then there's other aspects which are very common, like depression and anxiety. And there's something that the doctor should be looking at. Insomnia is also common. You need to work out what is the reason for the insomnia. It's not just a matter of giving them a script for a benzodiazepine. The insomnia could be that they're not comfortable, that they can't breathe, and you need to deal with those aspects as well, not just sort of go straight to pharmacology. And also just non-specific things like what do I do for pain and shortness of breath, and they can vary according to what you think is the mechanism. And in our clinic at Liverpool, me and the palliative care consultants and all the respiratory consultants will sit and discuss whether we think there's a pharmacological role. One thing that I've got an interest in and I've tried to help, it's a very disabling symptom for patients, is excessive saliva. It's very complex as to why that occurs. It's usually related to muscle spasticity and poor palatino-lingual muscle control. It is a risk factor for aspiration, and it significantly affects quality of life, including potentially limiting non-invasive mechanical ventilation, and it's very challenging. I would start with simple things like these anticholinergics first. Interestingly, we've started just using atropine eye drops and asking patients to put it under their tongue. They can get some bowel symptoms as a side effect. Amitriptyline is another option. We've got one patient that's on an infusion of this that was organised by the palliative care consultant in the community as a pump. That's worked well for that patient, and I've tried botulinum toxin, but that's had mixed results. If I was to use botulinum toxin, I tend to use an ultrasound guidance, because I find that just guessing where the gland's going to be doesn't tend to work, and I'll inject around 60 units. I can't think of the idea of charging a patient, so we find extra stock somehow and don't charge them. But it is expensive. That would cost $500. And just to finish off, just always remember it's a circle of care. The neurologist needs to probably do more than they have been in the past. We tend to not think about all these things. We hurry the patients, and it's sad that to hear when someone's in need of a doctor to help them and the doctor's too busy. But it's very important to make sure that the patient has a multidisciplinary team behind them, because otherwise they won't have the optimal care that they need. I'll finish there.